The brain is an organ that receives information and then passes instruction to the body. Now, if I told you my son was playing football and got hit in the head and it kind of rattled his brain, you would not be surprised that he might have some problems then, and not be surprised that he had residual problems the rest of his life. People don't seem to understand is that you don't have to have physical trauma. You can have visual trauma. You can have auditory trauma. You can have thought trauma, where you have been traumatized by something that happened, that you witnessed, that you were involved in, and that literally changes the brain chemistry. And that change is what we call PTSD. Now, the problem is that it's not the same for everybody. Some is more severe than others, and the treatment is not the same for everybody. And what we need to do is make sure that we have individualized treatment for a long-term chronic disease. There has to be a lifetime commitment to providing this person with care, and that is very expensive and it is very difficult, because if you're a therapist or a practitioner, as I am, working with somebody with PTSD, work with one person and then you come up and you start working with another person, I can't have a cookbook. It doesn't work, because individuals react differently and they have different coping skills. And that's one of the reasons why veterans groups seem to be as effective as anything else. One of the guys that I worked with, he had to learn to accept that he was going to be different the rest of his life, and he didn't want to talk to anyone unless they have been there, done that. And one of the first things he asked me about, because he heard that back during the Vietnam time I was a medic, and he wanted to know if I was a combat medic, because if I wasn't there in the blood and guts, he wasn't going to talk to me because he didn't think I could relate. The problem with medication management, and it's not only with the VA, it's across the board with all treatment programs. They have individuals who do medication management, and then they have individuals who do the therapy. And the separation of those two jobs doesn't really work with PTSD, because medications need to be evaluated, adjusted up or down on a very frequent basis. Because I'm retired and I have the time, I can take a large portion of my time and apply it to one or two individuals. Probably not practical in a large setting where you have people coming and going and you have a caseload. When services are delivered in a kind of cold, academic environment as opposed to a compassionate environment, the individual with PTSD is not as readily accepting of that kind of therapy.